Good morning, everyone, and welcome to this morning's webinar. So today's theme is urological infections. It's an area that remains highly relevant to everyday urological practice, and it spans conditions from both outpatient setting to life-threatening urological emergencies. So our first speaker today is Dr. Rashmika Magan. She's a medical officer at Groote Schuur Hospital in the urology department. Dr. Magan will be speaking on the approach to epididymo-orchitis, as well as genital ulcer disease. And she'll be taking through us a structured approach to diagnosis, investigation, as well as management. And we know with the evolving antimicrobial resistance patterns and changing treatment recommendations, it's important for us to stay up to date with regards to what's essential and optimal for patients. So Rashmika, thank you for your talk.
Okay, thank you. So as Simon said, my presentation is going to cover two quite critical urological conditions within the infectious disease and sexual health space. I'm going to be going over the new 2025 EAU guidelines on urological infections, as well as the 2024 European epididymo-orchitis guidelines and the South African HIV Clinical Society 2022 STI guidelines. And then in the end, there's just a bit of emerging clinical studies and resistant patterns that will shape our practice in the next upcoming years that I'll go through. Sorry. Okay, so epididymo-orchitis, as we know, is one of the most common urological diagnoses that we see, yet often misdiagnosed and mistreated. It can be acute, chronic, or recurrent, and epididymo-orchitis accounts for a significant morbidity, including abscess formation, infertility, and chronic scrotal pain. It affects men of all ages. I know broadly, generally, we subdivide them into men under the age of 35 who are in the STI category and men over the age of 35 based on their pathophysiology. But by definition, they're all inflammation of the epididymis and or testes, causing acute scrotal pain, swelling, and erythema. According to the EAU 2025, acute epididymitis presents as pain, swelling, and elevated temperature. And up to 90% of the cases is caused by migration of pathogens from the urethra to the bladder. Predominant bacteria we'll go through in the upcoming slides. Just to note that in the 2025 EAU guidelines, they've updated evidence for specifically on acute epididymitis, and they've sort of classified this as male accessory gland infections, or MAGI. And obviously with any acute scrotum, it's always prudent to exclude testicular torsion first, as we all know is a surgical emergency. And in bilateral cases, we need to consider things like mumps, and obviously in our setting, to not forget about TB. Etiologically, we have classified them into sexually transmitted diseases, non-sexually transmitted diseases, and non-infectious entities. So our sexually transmitted diseases, our main pathogens is chlamydia, gonorrhea, mycoplasma, urea, plasma urolyticum. And then our non-sexually transmitted diseases are predominantly our E. coli, any procedural catheterization, candida, TB. Mumps, brucella is quite rare, but obviously that's where our history taking is important. And then non-infectious is things like trauma post-vasectomy. It can occur idiopathically in 10 to 15% of cases, and then certain drugs can also cause this EPO. It's important to also remember our pediatric population when it comes to epididymo-orchitis. I think it's something that we don't often see if we're only working predominantly not in the ped space. But the approach would be to age stratify these patients. So, neonates and infants, we're going to think about structural causes, and their pathophysiology is similar to our men that are over the age of 35. So you'll think about your congenital associated kidney and upper tract abnormalities. So your VUR, your posterior urethral valves, ectopic ureters, anorectal malformations, neurogenic bladder. And all of these would cause like a retrograde flow of infective urine, which would be the mechanism. And then you get the cystic dilation of the prostatic verticals, and it's found to be a significant proportion of recurrent in prepubertal cases. In our prepubertal boys, the most dominant etiology there would be viral. So our enteroviruses, adenoviruses, Coxsackie, etc. There were also reported 3 such cases of during COVID, and then obviously mumps has become less prevalent since our vaccines. And then hyperspadias is also something to note. It's found in 18% of prepubertal epididymitis cases. So it's important to also clinically examine our patients. Our adolescent boys generally follow the adult pattern, so obviously work them up for STIs, contact tracing, etc. And then to reiterate our pathophysiology, so the retrograde ascent of the urine flow, post-viral inflammation for the viral infections, and then it can also be spread hematogenously for the neonates and for immunocompromised patients where we have breach of our blood epididymal barrier, which is because of the bacteremia. And then obviously our diagnostic workup in these cases is similar to the adult. The only adjuncts we're going to add on here is we're going to assess our upper tracts and perhaps get a VCU and MCUG for recurrent or second episodes to work these patients up for the cause of their EPO. And then obviously viral serology based on our clinical suspicion. And then management generally for the prepubertal kiddie first episode, no pyorrhea, no positive culture. We're going to be doing supportive management solely with analgesia, scrotal support, rest, and observation. Antibiotics are generally not indicated routinely unless you've got evidence of a bacterial infection. Yeah. So then with regards to our adults, similar with regards to our pathophysiology as described, and then obviously with our infections such as TB or brucella, we must remember hematogenous spread. And you can also get direct inoculation from our post-operative or post-instrumentation trauma, and then also inflammation sequelae, so your edema causing epididymal duct obstruction and essentially pressure necrosis and abscess formation. So it's just a nice diagram which kind of shows your different pathophysiology causes, so your edema, viruses, hematogenous spread. And then, I think I skipped something. So moving on to our clinical assessment and investigation for EPO. History taking is quite important. With the onset of pain, duration of pain, was there discharge, is there dysuria, the frequency. Obviously, our sexual history, travel history is also quite important, drug history. Examination is quite important, obviously, based on your clinical suspicion. Any acute onset scrotum is going to be a torsion until proven otherwise, so we need to work the patients up for that. And then investigation-wise, we'll always start with the urethral swab, first void, nucleate amplification testing, mystery urine MCNS, and our ultrasound. And then second line, you'll go into your sero testing as well as your blood work. And then special cases will depend on your pathogen that you have in mind. Our differential diagnosis for EPO is obviously the main one, torsion. We must make sure that we don't miss a malignancy. Obviously, our Fournier's, orchitis, hydrocele, epididymal cyst. And yeah, I think the main thing is to just not miss a malignancy that has like superimposed infection. The EAU 2025 treatment guidelines for EPO has changed slightly, where the ceftriaxone stat dose for gonorrhea-like disease, gonorrhea-likely EPO has increased from 500 milligrams IM stat to 1 gram. And then dual therapy with azithromycin is no longer recommended as a first line due to the rising resistance for azithromax to gonorrhea. And then doxycycline still remains our first line choice for chlamydial coverage. And obviously, we consider parenteral treatment for patients that are not clinically, that are systemically unwell and not responding within 72 hours to the treatment that's been given. Pretty much everything else is sort of saying the same with your 2 weeks treatment of your ofloxacin or levofloxacin treatment. And then with regards to the other types of, so like not our general treatment, the specific types of treatments, I think I'm not going to go through each different type of first-line antibiotic, but it's always important I think from a practical point of view to document your indications before prescribing. And then also partner notification for STIs is mandatory in confirmed or suspected cases, so we must always practice that. And again, if there's no improvement within 72 hours, we need to investigate the patients up. Remember our ultrasounds, remember to repeat cultures, remember to review our initial choice of antibiotics. In our setting, remember to test for TB if it is something that is clinically suspected. And then especially with the azithromycin resistance globally, to always remember what treatment you've used and within that 72 hours, recheck and follow those patients up. And then with regards to supportive care as well, sometimes we forget about that. So scrotal elevation, NSAIDs, rest, abstinence from sexual activity as well. We need to counsel our patients and work them up. I think very often we get a phone call about a colleague that is diagnosed EPO, and we don't properly manage these cases, and it is something that we should be doing, especially with the resistance of antibiotics. Within our South African context, obviously difficult because we're always in a resource limited setting. But within our guidelines from 2022, EPO is excluded from our STI syndromic management. So we manage it as per the EAU according to our workup. And then the only patients are HIV negative patients with epididymitis and urethral discharge we treat for STI, and our HIV positive patients with epididymitis without obvious STI risk. We have to also remember to have a high clinical suspicion for TB. And with regards to TB, remember your beaded epididymis on palpation to look for signs clinically, etc. for those patients. Our complications for epididymo-orchitis is abscess formation, be it epididymal or testicular, chronic scrotal pain, subfertility, as well as obviously fornius gangrene. Again, that 72-hour rule to check our patients. Are they improving? Are they not improving? Check compliance of their treatment. Exclude abscess with your ultrasound. Review your antibiotic choice. Consider alternative diagnosis such as malignancy. For our subfertility, it's quite an underappreciated sequelae of the illness. And I think it's quite important for our young men to counsel them for partners to be notified if there are STIs in the mix as well. And I did find out, I know at GSH we have a sexual health team that can actually help you with that, to contact partners and stuff for contact. So the second part of the talk is on genital ulcer disease. So an overview for genital ulcer disease is that by definition, it's a loss of skin mucosal integrity of the genitalia. Clinically, it appears alone. Clinically, to identify this alone is insufficient. It's been proven in multiple studies that the diagnosis of genital ulcer disease is unreliable, and as clinicians, we actually misdiagnose it 30 to 40% of the time, just relying on clinical appearance of the ulcer. The NICD sentinel surveillance from 2021 to 2024 shows that our most common ulcer in our country is still herpes simplex, but syphilis has been rising because there was quite a shortage of benzathine penicillin in 2016, but now it's back in stock. So hopefully we'll see a decline in that again. And then obviously chancroid and donor-venosus have become uncommon in South Africa over the past few decades, but they are still illnesses that can pop up. So we're going to go through those. With regards to, okay, let me go. So broadly, we generally classify ulcers as painful or painless ulcers. We know that any painless ulcer is syphilis until proven otherwise. And any painless genital ulcer requires a TPHA and RPR screening. And then given the prevalence of HSV within our country, as well as its pathognomic features of being recurring, it's also important to do a PCR swab of the base of ulcers. It's far more sensitive than any other preparations. With our chancroid, like I said, it's still rare. It's now rare, but it still exists. So if you see anyone with painful ulcers with a soft base, ragged edges, tender, fluctuant, unilateral bubo, and you must think of chancroid. And then our LGVs are quite underdiagnosed, especially in our population that partake in anal intercourse. It's important to investigate and remember our serovars and our nuclear amplification tests for that. And then any ulcers that are lasting more than 6 weeks, we must always think malignancy as well and not miss that. Our diagnostic approach to genital ulcer disease is obviously history examination and investigation. In our history, it's a targeted, we look at our sexual history, last contact, is there condom use, the onset, duration, and reoccurrence of the ulcers, any travel history, drug history. Are there associated ulcers elsewhere? You need to examine your patients properly for the number, the size, the borders, injury, is it indurated, is it soft? Again, the main determining feature, painful, painless. Is the base of the ulcer clean or dirty? Is it purulent, granular matters? Examine the patient's lymph nodes. Is it unilateral? Is it bilateral? Obviously, your oral cavity, skin joints, it's quite a extensive examination. Obviously, we don't have a lot of time for that sometimes, but it's just to have in the back of your mind so you know what to look for. And then with regards to our investigations, so our simplex, HSV, PCR swabs for the ulcer base, our syphilis serology, we'll go into details in a bit. And then our HIV serology obviously should be offered to all patients in our setting as well. And then with regards to the nucleic amplification tests, in the public sector, it's not always available. It is apparently available at Groote Schuur. So I think there should be a drive to getting these done more frequently for patients or referred for that at least. And then HIV testing should, like I mentioned, be offered to all our patients with ulcers. And it's also important, I think, because we don't see, not the same clinician sees the same patient each time. So when you are actually with the patient to document what you saw, it really helps the next person and with follow-ups with regards to treating the ulcers, the disease. So herpes simplex, being the most prevalent one in our setting. So yeah, primary initially presents with like general flu-like symptoms, as well as these painful cluster papular lesions on the skin that crust, and you get bilateral lymphadenopathy. The incubation period is generally about 4 days. And the gold standard for diagnosing this is with a viral culture swab, which takes about 5 days to give us results. And then our antibody ELISA tests distinguish between the HSV1 and HSV2 glycoproteins. And then our antigen detections cannot distinguish between the two, but it's just the types of seros we have available. With regards to our management for HSV, we have our acyclovir and our valacyclovir. Patients are often quite devastated by the news of HSV, so I think it's also important to spend time counseling them on the fact that it is an illness that they will have for life, but it is quite manageable. And asymptomatic shedding occurs, so you also need to counsel them on the fact that it can be transmitted even though they do use condoms during intercourse. And then the suppressive therapies reduce transmission by about 50%. Again, partners should be tested and counseled as well. Within our pregnant population, primary HSV, if they have primary HSV near to term of their pregnancy, we must discuss options of C-section delivery. And then valacyclovir is preferred over acyclovir in our setting due to its improved bioavailability. And obviously the fact that it's taken once a day as opposed to twice a day improves adherence. And in our HIV positive patients, the suppressive therapy with valacyclovir reduces our HIV viral load, which is an additional benefit to the drug. So our EAU 2025 guidelines has actually added a section on herpes simplex virus, which I've summarized in the next slide. Just to finish off for HSV, we know that we can get a first episode. Recurrent episodes are treated differently, as denoted on the slide. And then we also have our suppressive therapy. So this is indicated if there's been more than a 6 times recurrence within a year, or if there's significant psychological morbidity, if the patient is HIV positive as well. From the AU guidelines for 2025, the section basically reiterates the current practice of clinically examining the ulcer solely is not sufficient. All patients need to be treated for pretty much all episodes, but especially the first one. And then your topical antivirals have a limited role. They should be used as an adjunct only, and your topical steroids are not recommended. With regards to screening, it's not recommended for asymptomatic individuals and not routinely recommended. Again, the special situations, so during pregnancy, they also add that acyclovir and valacyclovir are both safe in pregnancy and should be considered for suppressive therapy from about 36 weeks of if primary HSV is present near to term of the pregnancy, and discuss obviously the C-section options. But it's nice that it's now been included as its own section. Moving on to syphilis. So syphilis, as we know, emerged in the 16th century during the war in Italy, Naples, during the French invasion. And at the time was known as the Great Pox, as it spread throughout Europe. Many, many years later, gonorrhea emerged in 1879. And then in 1943 was when we only had the introduction of penicillin, which is quite a long way off. So T. pallidum, usually our incubation period is 10 to 90 days, and it's a coiled bacteria which demonstrates this corkscrew motility and manifests as these ulcers, painless, or chancres. So it's ulcers that form, that heal within 3 to 6 weeks, and then form these firm, non-tender inguinal, they're associated with this non-tender inguinal lymphadenopathy as well. So with regards to syphilis, you get primary, secondary, latent, and tertiary. We don't see tertiary syphilis that often anymore because of obviously the introduction of penicillin. And primary initially occurs and then heals within 3 to 6 weeks. Secondary would then subsequently be within the 4 to 10 weeks after that, where the pathognomic manifestation would be these maculopapular rashes on the palms and soles of the patient's body. And then with regards to our serotesting for syphilis, our TPHA remains positive for life, and our RPR is used to monitor the treatment response. So with our RPR, we can expect a fourfold drop within 6 to 12 months of treatment. So that's the one to remember. There are a bunch of investigations. I think predominantly in our setting, it's just RPR and TPHA. They're quite sensitive and specific for syphilis. But you also have confirmatory tests like your treponemal enzyme immunoassay, as well as fluorescence treponemal antibody absorb testing as well. But the main one, I think, to monitor like a treatment response is, like I said, your RPR, which has a fourfold drop within 6 to 12 months of treatment. And then obviously our treatment, as we know, is based in penicillin, which is an IM dose, 2.4 million units. If the patient is allergic to penicillin, then we go ahead with doxycycline. With regards to our treatment here, it's obviously important to remind patients of the reaction that can occur. I can never pronounce it for the life of me, but I think it's Jarexheimer. So to warn the patients that they can experience this fever, chills, and rash for 2 to 8 hours after that first dose of penicillin. It's more common in secondary syphilis, but it is self-limiting. So it's not necessarily treated. It's usually just treated with paracetamol, and you don't stop treatment if they react. You just give them the paracetamol. Again, important for contact partners. So with regards to primary syphilis, you're gonna contact partners within the last 3 months. Secondary would be 6 months, and tertiary would be 12 months. Moving on to chancroid, LGV, and granuloma, so Klebsiella donovanosus. So our chancroid is a Haemophilus ducreyi, which is a gram-negative bacilli, which is rod-shaped, anaerobic. So that manifests primarily as this painful ulcer with soft base. The patient needs to be obviously investigated with regard, and a thorough history taken about their travel history, sexual history. The incubation period is about 21 days, and it essentially is caused by the breach in skin and inoculation of this bacteria, which then releases like this lethal toxin causing necrosis and ulceration, but it evades apoptosis. With our LGV, it's increasing in our population that partakes in anal intercourse. To remember, patients who have traveled to these endemic areas to be worked up for that. And then here our nucleic amplification testing, so our serovars, is pretty much the only way to diagnose it. It needs to be requested specifically. And their treatment of choice here would be 3 weeks of doxycycline. Shorter courses generally tend to fail. With regards to our granuloma inguinal, our Klebsiella granulomatous gram-negative bacteria. So these lesions are highly vascular. They bleed on to contact. And our diagnosis here is our Donovan bodies, which is your intracellular rod-shaped organisms in the macrophages. And that's diagnosed with the tissue smear, which remains the diagnostic standard. With regards to treatment there, it's your Zithromax 1 gram weekly for 3 weeks. And these are just photos of the different ulcers. I'm just going to go through quickly because I think I'm running over time. But within our setting, obviously resource limited, we follow a syndromic management standard. So we cover HSV and syphilis for a minimum, and then we add chancroid coverage when there's based on like the local epidemiology. And then with regards to our NICD sentinel surveillance, validates these algorithms every 2 to 4 years to ensure that we cover these dominant pathogens and these things are treated appropriately. This is just emerging data that's come into play. So there's been noted a six-fold increase in resistance of ceftriaxone in the last 4 years, which is quite alarming. So the resistance for gonorrhea. So within South Africa, this hasn't really been formally surveilled within our population as yet. But with the shift away from azithromax, therapy is now this ceftriaxone is in all the major guidelines. And then there's a new antibiotic, which is called soliflodacin, which is a first-in-class mechanism which inhibits your DNA gyrase via the binding site, which is actually active against the ceftriaxone resistant strain. So that's got like phase 3 data published from 2023, which shows no inferiority to ceftriaxone, but it's not yet registered in SA. And then with regards to mycoplasma, it's now recognized in the 2025 EU guidelines as a genuine pathogen causing EPO, not just urethritis. It's with this macrolide resistance crisis with azithromycin historically being used for chlamydia and some genitalium, it has a global resistance rate now. So we need to be moving towards nuclear amplification testing for this genitalium, especially in tertiary centers like ours, where it actually is available. And then obviously now we've got various methods of point of care testing that's going to become available to diagnose these diseases quickly within the same consultant setting, which is quite exciting, and hopefully it will become available to us quite soon. And then also the note on, I think this is pretty much the last slide on fertility. So male fertility with genitalium is gaining significant traction. When you see a young man with epididymitis, you need to think about his fertility. We need to ask him about family planning. The choice of antibiotics needs to be looked at and follow up. And we need to be more cognizant of these things that we just so blindly prescribe, especially with the quinolone resistance issue for enteric pathogens increasing in our country. It's just something that we need to be cognizant of. So takeaways, sorry for going a bit over time, but obviously in an acute scrotum, we always have to rule out torsion first. Age is our guide when it comes to antibiotic choice with regards to STI versus non-STI. So more than 35 versus less than 35 years of age. We must always swab our ulcers before we proceed to treat, before we give any antibiotics. Clinical appearance is not the only thing that should be used when we are diagnosing these ulcers. We must use our seros and our other investigations in order to make a proper diagnosis. Benzathine penicillin is back in stock, so hopefully we'll see a drop in syphilis again. And then obviously we need to test all of our patients, and then this macrolide resistance testing. Yeah. About it on my side. Thank you.
Thank you, Dr. Magan, for that presentation. Do we have any questions on the floor or in the chat? We have a question from Prof. Las.
Thanks, Rashmika. Just a question about ofloxacin and levofloxacin in the first line treatment. I always used augmentin. Is that, am I just showing myself as a dinosaur? Is everyone else using a quinolone or over 35 enteric epididymo-orchitis?
So the question is for the treatment of enteric epididymitis, the first-line treatment, is it ofloxacin or levofloxacin, or is it augmentin? I must be honest, before doing the deep dive on the guidelines and what we should be doing, I've also been prescribing augmentin. But I think from the literature and from the guidelines that I've read. I don't know if anyone else has anything else, but we should be using the ofloxacin and levofloxacin from what I see.
While you're there, you implied that HSV type 1 and 2 can cause genital ulcers. That was something I didn't know, and that a condom use does not stop transmission. Is that just when someone's infected, or is it a lifelong thing?
No, so it's a lifelong thing. So they say that you have the asymptomatic shedding even when there's no active ulcer. So you can actually apparently transmit the illness. I mean the disease when you don't have an active ulcer. So they say that it should prevent it condom use, but it doesn't always. And then with regards to the HSV1 and HSV2, there's actually a study I read in the UK about, so I think it was UK or Sweden, can't really remember, but about the fact that now that the younger population have all started partaking a lot more commonly in oral sex, they've now you can actually get the mix up of the two. Yeah.
Last question, your slides implied that you should do an ultrasound torsion, but I'm sure you didn't.
No. That's the clinical diagnosis, yes. It's a clinical diagnosis, torsion. Once you've ruled that out, yeah.
Sorry, in the part, well, if the GP or casualty phones and they say they got epididymo-orchitis and they say, are they going to write up KEF and the Zethro and Flagell and sort of just to cover for everything. And I mean, the rationale there is to cover for that anaerobic potentiality. And if there's maybe an infected female partner, so there's no need for metronidazole at all.
Not what I've read from the updated guidelines, no.
Okay.
Yeah. I don't know if anyone else has seen anything else.
Good. Thank you for that, Rashmika. So our second speaker this morning is Dr. Anja Badenhorst, also a medical officer here at Groote Schuur in the urology department. Dr. Badenhorst will be speaking on emphysematous pyelonephritis. This is one of the most severe presentations of the urinary tract infections that we encounter in our urological practice. So these patients are often require complex decision-making about antibiotics, drainage, as well as surgical intervention, and it makes for an important topic for us in urology. So Anja, thank you for presenting this morning, and we look forward to your talk.
Thanks. I just want to get my slides. Okay. I don't know if it's sharing. Is it showing? Okay. Ooh. Good morning, everyone. I'm going to go into a deep dive of emphysematous pyelonephritis. So it was first described in 1898 by Kelly and McCallum, where they saw a gas-forming renal infection. The patients presented with pneumaturia. Then in 1962, Scholz and Clorfin coined the name emphysematous pyelonephritis. So in the pre-1970s, if you were diagnosed with emphysematous pyelonephritis, the mortality rate was as high as 78%. And then Wang and Tseng came along and they described the gas pattern seen on CT and they linked it to the prognosis of the patient. So luckily today, with modern medicine, the mortality rate can be as low as 13.5% when you combine the drainage and the medical therapy. So yeah, this revolution was really necessary, and we reserve a nephrectomy as salvage therapy. So which patients are at risk for getting emphysematous pyelonephritis? So 95% of our patients are diabetic. So that is the biggest risk factor. Diabetes causes target organ damage, and it just creates a whole host of factors that makes it more ideal for the bacteria to predominate. And then most of our patients are female. It's a 6-to-1 ratio. The mean age is 55, and up to 10% of the cases can be bilateral. And they say the left kidney is usually favored. So regarding diabetes, the hyperglycemia fuels the fermentation. And then the vascular target organ damage the patients get also causes tissue ischemia, which creates more desirable environment for the bacteria. Usually you see it in patients with urinary obstruction, so they might have a stone and there's papillary necrosis, and then the stasis of the urine and the raised pressure, and the more poor perfusion just creates more desirable environment. And then our immunocompromised patients, HIV, so any other condition that makes you immunosuppressed also creates a more impaired, it can't contain the infection, so it just makes it more necrotizing infection. So there's 3 factors that you need for emphysematous pyelonephritis to develop. And then actually, if you remove one of them, then emphysematous pyelonephritis cannot happen. So you need to have these 3 factors for it to happen, regarding the pathophysiology. So firstly, you get your gas-forming pathogens. They are facultative anaerobic gram-negative, so your E. coli, Klebsiella pneumonia. So these bacteria, they take glucose and lactate and they ferment it to carbon dioxide and then hydrogen and nitric oxide. Nitrogen, sorry. And then it's actually, so CO2 is rapidly reabsorbed. So the gas we see on the CT is hydrogen and nitrogen, actually. And then the second factor, you need to have a high tissue glucose. So once again, glucose is the substrate, and glucose and lactate undergoes the fermentation to form the gases. And then the third factor is impaired perfusion. So diabetes causes target organ damage, so they will have microangiopathy. Or if there's any obstruction that then cause a hypoxic environment for these bacteria to grow. So which organisms then cause, like I said, it's predominantly E. coli. They're the most common and they are a rapid fermenter. You also see Klebsiella pneumonia, and then in your patients who have staghorns, you can see Proteus mirabilis. And then of concern is that these organisms usually have extended spectrum beta-lactamases. So they inactivate the bacteria after antibiotics that's supposed to work on them. So that's why we usually give an empiric carbapenem to cover for these ESBLs. But it can also then cause a problem with our antibiotic stewardship. But just to be aware that if you are at a facility that has high ESBL rates, please start them on a carbapenem. Then you also need to be aware of your immunocompromised patients. They are at risk of getting fungal infections. So if you see that the patient is not responding to your treatment, maybe they have also a underlying fungal infection. So how do these patients present? Usually they have fever, chills, they will present with flank pain, abdominal pain. The most worrying symptoms or how your patient will present, usually they can be in septic shock. So always have a low threshold of suspicion. If you see a diabetic patient that might present in DKA and they're shocked, they have a high fever, they have flank pain. And then they can also have acute kidney injury on their bloods, suggesting there's an underlying obstruction infection going on. And then, so some of the red flags, if there's a patient admitted for pyelonephritis, maybe they didn't do a CT scan and they're not responding to the antibiotics, it should alert you that something else is going on. So then you need to order a CT scan. And like I said, if the patient presents with a DKA and they have a marked hyperglycemia, you also have to be alert if they're presenting in septic shock. It can be emphysematous pyelonephritis. And then any patient that's rapidly declining, you should also have a low index of suspicion. And then at very advanced stages, they can even present with flank crepitus, but that signifies a very severe picture. So what will you see on your bloods if a patient has emphysematous pyelonephritis? They will have a leukocytosis. And then in the immunocompromised patients, if they have a leukopenia, it's a poor sign. They have an acute kidney injury, either from the sepsis or if they have a stone that's obstructing the system. The patient is usually diabetic, so they have hyperglycemia, they'll be acidotic. They can even present in a DIC type of picture from the severe sepsis. And then it's very important that you follow your surviving sepsis guidelines. You take your blood culture so that you can guide your therapy according to the causative organism. Then there is prognostic indicators. So if your platelets are less than 60, it's a predictor of mortality and possible treatment failure, as well as patients with a low albumin. That means they have poor reserve, and it's also linked to treatment failure. Then if the patient has a rising serum lactate, it's a marker of hypoperfusion, and also your capillary refill time, according to the Andromeda trial, which is not inferior to a lactate. So these are just some prognostic indicators you should be aware of. So once we've done our blood cultures, we need to send the patient for a CT scan. So you'll send him for a non-contrasted scan, because you also need to rule out any possible stones. So your first line would be to order a CT scan. You can do an ultrasound or KUB X-ray, but that will not diagnose the condition. So what do we see on the CT scan? You'll see gas in the either if it's in the collecting system, it's a pyelonephritis. If it's in the renal parenchyma, it's a pyelonephritis. Emphysematous, pyelonephritis. So there's also what they describe the crescenting or rim gas, which suggests that there is extrarenal spread of this condition. So there are two classifications. So the first one is the 1 classification. The type 1 gives you a 69% mortality rate prediction. It's when there's no fluid collection, and it just describes that there's a fulminant destruction of the renal parenchyma, and then it just gives us a mortality prediction. And then the type 2 that's described is when there's a contained infection with fluid in the parenchyma. And then just to be aware of your, if your platelets are less than 60, then it makes the mortality rate go up as well. Then the classification we use the most is the Wang and Zheng classification. So your class 1 is your emphysematous pyelitis. So that usually responds to medical therapy. Then your class 2 is when the gas is only in the parenchyma and there's no extrarenal extension. Type 3A is when it's in the perinephric space, so it's contained within gerotas. And then your type 3B is when it extends to the pararenal space, so beyond your gerotas fascia. Type 4 is when it's affecting both kidneys, so bilateral or solitary kidney. So that is the one we're the most concerned of, because it has a high mortality rate and probably the most difficult to treat. So it's also important just to have a differential diagnosis. So if it's not emphysematous pyelonephritis, if it's just in the collecting system, it's a pyelitis, or it can just be a renal abscess, but then there won't be gas, it will just be a fluid collection. And then your xanthemus granulomatous pyelonephritis, you also won't see gas, just to be aware of the other differentials that can present like emphysematous pyelonephritis. So why is it saying the battery is low? Sorry. Sorry. So how do we treat our patients? So the first step, you have to resuscitate your patient first, because they're mostly in septic shock. So you'll follow your surviving sepsis guidelines. You will give them fluids, control the sugars, and then you need to decompress any obstruction. Then you will give them empiricarbapenems and de-escalate according to your cultures. And then you will send your patient to interventional radiology to do an image-guided percutaneous drain. And then if that fails, a nephrectomy is then the salvage surgery. So yeah, so we stabilize our patient, we give them crystalloids 50 moles per kg in 3 hours, and then you'll start your noradrenaline if their MAPs are still below 65%. You will give the patient a sliding scale according to their glucose and keep it within 6 to 10 millimoles per liters. And it's very important that your patients are treated in the appropriate facility. So most of them will need ICU admission if they require inotropes for their shock. And then urgent decompression, either with a DJ stent or percutaneous drain is needed to disobstruct the patient. So regarding the antibiotics, like we said, we'll give them a carbapenem, so either meropenem or atapenem if you are in a facility with high ESBL rates. Alternatively, you can give them piptaz, but just be aware if there is high ESBL rates, it might not respond. And it's just very important to start it as soon as possible, and then you'll de-escalate it according to your cultures. And then if the patient is immunocompromised and they're not responding to antibiotics and you suspect a fungal infection, you'll cover them with fluconazole. So regarding the percutaneous drainage, so the patient will be then referred to interventional radiology to insert a percutaneous drain into the gas or fluid-filled cavity. And then you can even, if there's multiple, if it looks loculated, you can even more than one drain can be needed. And yeah, if it doesn't respond to your medical management and the percutaneous drainage, then the salvage therapy is a nephrectomy. But that we only reserve if it's really needed, because we always try to preserve the kidney as much as we can. But if the patient has a thrombocytopenia and a hypoalbuminemia, it's already a predictor that our percutaneous drainage might fail and they might need a salvage nephrectomy. Yeah, but this is just our salvage therapy. It's not, it will never be the first line of treatment for a patient. So what do we do now in a patient who has bilateral emphysematous pyelonephritis or they only have one kidney? So you would then do bilateral drainage. You will not perform a nephrectomy in this patient as they won't have any kidneys left then. And then if they're very unstable and they have a severe AKI, you will also need to refer them to renal for emergent dialysis, just to keep the kidneys, to preserve the kidneys as much as possible. If they have a solitary kidney, again, you will try to reserve the only kidney they have left. You'll do a percutaneous drain and prolonged antibiotics. So this is just a graph showing the mortality by management strategy. So prehistorically, in the 1970s, the mortality rate was 78%. And then when you only treat it with antibiotics, it's 50%. In emergency nephrectomy, which is your salvage therapy, will be 25%. Yeah, and then your percutaneous drain and medical, it's 13.5%. So there's still a few debates that's unresolved. So when will we say a percutaneous drain has failed? There's not really any evidence to tell us that. And then they're saying we should give everyone a carbapenem empirically, but it's also, are we then going to create any resistance? So we just have to keep it in the back of our mind, and then always just to de-escalate our antibiotics once we have cultures. And if we have to do a salvage nephrectomy, are we going to do it open or laparoscopic? I don't know. And there's some emerging evidence that regarding novel biomarkers. So we know about NGAL that can detect acute kidney injuries earlier. I don't think it's specific to emphysematous pyelonephritis. And then there's also validated risk scores that can help for the risk rate. But yeah, in conclusion, it's just important to always remember if you have a diabetic patient with pyelonephritis that's not responding to your therapy, you need to send them for a CT scan. You'll do a non-contrasted CT scan. If there's gas in the parenchyma of the kidney, it's an emergency. You need to refer them to urology. So that we can arrange a percutaneous drainage, and then it's always important to relieve any obstruction if they have a stone with either a stent or nephrostomy, and then to give your antibiotics as soon as possible and to follow your guidelines, because you need to resuscitate the patient always first. These are my references. And then, if you have any questions.
Thank you very much, Anja. Are there any questions from the floor or any questions from the chat? Question from Professor Lazarus.
Just two questions. You gave us a milligrams per deciliter, creatinine level of 1.4. We're not familiar with that. How do you convert that? Because you see that commonly in American literature, that we use micromoles and liters. So how do you make conversion? What does 1.4 represent that you showed on the slide?
Quick maths.
So how do we measure our creatinine? Good. So she gave us milligrams per deciliter, which is what the Americans use. How do you make the conversion? As you can see this in the lifetime a lot.
You make it calculated.
So the answer is quite simple. The times by 100. 1.4 becomes 114 micromoles per liter. That's not quite true. It's closer to 90, but for simple terms, it's 100. You also confused me a little bit because you spoke about WAN types and classes. I quite understand those things. I'm not familiar with them. Can you just explain the different classes or grades of emphysematous versus you spoke about two different types, the WAN type, which I hadn't heard of before.
That's just to describe the one as fluid, the other one, so the one that doesn't have fluid, it's more destructive, the type 1. And it just says that the mortality rate is higher than because it's not contained. But we don't use that.
Struggling to understand
It's two different classification systems.
We just finally say they always ask this one, but we don't use it. So it's pretty.
But can you explain why having fluid, because you're going to have fluid in the plating system, aren't you? So I'm not sure what they're trying to communicate there by saying that if you've got fluid, it's worse.
It's better. It's when you have parenchyma without a collection, it's worse, which makes sense because your drain's going to do what? It's not going to drain necrotic. But the fluid is a better prognostic feature.
The classes are in fact what we used to call grades, is that right?
That's good.
Anyone got them in their head? 1, 2, 3,
yeah.
Let's hear it.
So one is emphysematous pyelonephritis. It's only in the collecting system. And then 2 is if it's in the parenchyma. 3A is it's perirenal. 3B is pararenal, and 4 is bilateral solitary.
You call those classes or grades?
Great.
Grades.
I
Classes.
I
To change
I think yeah, it's great.
Last one.
Is it close? I don't know.
We got a question from the chat here, Anja, from Dr. Manu, asking, would you routinely place a urethral stent for all EPN patients given the pathophysiology?
I will put up a DJ stent if there's a source of obstruction. So if there's a kidney stone or if there's compression of the ureter causing hydronephrosis to relieve the obstruction.
I guess it's would you place a stent for or would you perk? That's what this is.
No, I won't routinely place a stent if there's no indication, if there's no obstruction. No.
And then, Anja, you mentioned on the workup that dirty shadowing. So these obviously observer dependent, but as urologists, you know, the ultrasound is an extension of our clinical exam, so we should be quite skilled at picking that up. But what is dirty shadowing? What is it? Why does that happen? Because it's quite unique to A in the kidney, which is obviously the diagnosis of EPN. So what is that?
I think it's the reverberation of the, I don't know, the
So yeah, the soft tissue or kidneys, etc., transmit the echoes. Obviously, when it's a stone or hard structure, it gives you the classic acoustic shadow, so no echo goes through. But when it's air, it's got acoustic impedance, so it actually transmits the signals back to the transducer, so it makes everything a bit. So you can actually see that sometimes if you do an ultrasound guided PCNL, scan the patient and when you put up your ureteric catheters, etc., it gets into the collecting system. You can actually see the ultrasound. It's quite different afterwards. So it's just that transmission of the sound. Are there any other questions? I think these were two excellent talks this morning. Thank you very much, Anja and Rashmika, for your contributions. And yeah, thank you, everybody. Have a lovely weekend, and we'll be back again next week, I assume. Take care.